Hello, my RT230s. Again, we are going to delve in the exciting realm of mechanical ventilation. This time, this is Egan's Chapter 46, Physiology of Ventilatory Support. Don't mind the RT230 Miss Carmona because this was her slides. Props to her. Let's get started. So when we are putting patients on mechanical ventilation, remember, they are in acute hypercapnic respiratory failure, or in other words, they are in ventilatory failure. All right, hypercapnic respiratory failure. Remember, hypercapnic, so their PaCO2 is high and their pH is low, or that's going down, it's decreasing. Okay, so at this point, they are not ventilating at all because their PaCO2 is increasing. That is why they are failing when they are ventilating. Okay, so we got to ventilate for them. All right, so the assumption that mechanical ventilation will improve minute ventilation and thus alveolar ventilation, by which PaCO2 will be normalized. And that's what we need to do. We need to increase our alveolar ventilation, therefore improving our minute ventilation. And this is based on either manipulating our tidal volume, our frequency, our respiratory rate, or both at the same time. And again, these two, when multiplied together, gives us our minute ventilation. And again, it is these two that affect our PaCO2. So here, minute ventilation again. There's your equation, alveolar ventilation. Now notice that we have our tidal volume minus our dead space. Okay, then we times our frequency. So dead space we do have to consider, and dead space is calculated by 1 ml per pound of ideal body weight. So if I'm 73, actually that's mLs. I'm sorry, not kilograms. It's mLs. So when we move on here, so when we talk about alveolar ventilation, what we have to understand is that our PaCO2 is inversely related to alveolar ventilation. So if we improve our alveolar ventilation, then we decrease our PaCO2. Okay, but then if our PaCO2 increases due to ventilatory failure, then our alveolar ventilation decreases. That makes sense. You can't ventilate through the alveoli, hence you have a buildup of CO2 in the blood. Right? So again, we talked about VQ ratio. We talked about that the apices of the lungs has a high ventilation perfusion ratio, and then the base of the lungs have a low VQ ratio, and that deals with the fact that blood flow is greater at the bases due to gravity. Okay, and so here sometimes positive pressure ventilation can increase in relation to non-dependent regions that may not need it because they might have low blood supply. Positive pressure ventilation, hey, they're equal opportunity people, so they'll spread the pressure wherever it wants to go. All right, so sometimes if it goes to a region of less blood supply, it's going to create a lot of dead space. So in that, if you have a lot more dead space versus blood supply, then you will have a high VQ ratio. Okay? Caused by inactive diaphragm and chest wall, that's why the pressures go willy-nilly all over the place. They might go to dependent regions or non-dependent regions. So therefore, our positive pressure ventilation tends to worsen a VQ and contribute to an increased PaAO2 value. Okay, so just remember that, because again, with positive pressure ventilation, it can create a lot more high VQ ratio places, and that does increase our alveolar air equation. Okay, so when we're talking about alveolar and arterial carbon dioxide. So normally our alveolar CO2 and our arterial CO2, they equal 40 milligrams of mercury as equilibration occurs across AC membrane. So that is our norm. We want 40. Okay, so if I have an increased volume of CO2 or I have a decrease in alveolar ventilation, that's going to cause, that's normally the case. Because if I can't if my ventilation in my alveoli isn't happening due to shunt, due to atelectasis, then guess what? I cannot get my CO2 to go into the alveoli to be breathed out into the air. Okay. So also, increased dead space of tidal volume can also increase the PaCO2. How? Because I have a lot of dead space versus tidal volume. Dead space is just lingering around. It's turbulent flow. It's hanging out in the circuit. It's hanging out in the airways. And so if it is still just hanging out, that's why I'm not blowing out my CO2. All right, so let's just say if I have a lot more air that's turbulent, it's trapped in the airways, and I'm trying to let my CO2 out, but yet I still have some turbulent flow in the alveoli. Guess what? My CO2 can't cross over because there's a lot more air molecules, whether it be oxygen, whether it be CO2, and it's all hanging around, just having a great party, and the CO2 wants to get to work, but it can't because there's a party in the way. All right, occurs due to excessive PEEP. So when you have excessive PEEP, and you'll hear this a lot, when you have excessive PEEP, it impedes your cardiac output, it impedes heart rate, and that's because it has a diverted blood flow. Okay, so if I have extra PEEP, I can put a lot of pressure on the walls of the heart, or should I say the heart is trying to compress and expand. And so if my lungs are giving the heart a really big hug, my heart can't pump, right? So if it tries to expand, guess what? It can start to impede certain capillaries, and it might divert the blood somewhere else. There could be a blockage based on pulmonary emboli or emphysema, where there's just damaged alveolar walls. Results in high VQ ratio because all ventilation and excess of perfusion is wasted. Again, it is a high VQ when you have more air than blood flow. So let's take a step back. Let's talk about acid-base balances. We did have ABG quiz, and we also had an ABG exercise as part of the homework. All right, so let's kind of delve into this. Respiratory acidemia or acidosis. Respiratory acidosis, basically your PaCO2 is greater, is high, and your pH is low, causing an acidotic state, and this is the culprit, which is your respiratory. Okay. So this is inadequate alveolar ventilation, and so we need minute ventilation to correct. There are times where patients are going to be anxious, which will cause your ventilator asynchrony. We talked about that in the last lecture. And this is just this is where there's a disconnect, or there is a difference, I can say difference in opinion on the way the patient wants to breathe. The machine wants the patient to breathe one way, the patient wants to breathe another way, so therefore there's some type of disagreement and they're not syncing together. Okay. I did talk about tube compliance, and that's whatever the tube compliance is times PEEP minus or PIP minus PEEP. That's going to give you your compressible volume loss. Remember, tubing compliance, if I start increasing pressure in our corrugated tubing, the blue ones, it can kind of give way, it can kind of expand. All right, so that's where you get some volume loss because it gets trapped in the circuit. That's why my very first lecture I talked about, if you created this very, very long circuit, and you have me in one end of the room and the machine at the other end, and you give me this 5-foot long circuit, guess what? I may not get that tidal volume. I might get low tidal volumes because it's trapped in the circuit. Okay, so and therefore that comprehensible volume loss in that example is going to be very less. Why? Because my tubing compliance is going to be much higher because I have longer pieces of tubing. Okay, so now our comprehensible volume loss should be at least 1 to 3 mLs per centimeters of water pressure. That should be it. The beautiful thing is that modern day ventilators now compensate for tube compliance, so therefore whatever volume you are getting that the machine is reading, that is the actual volume. You don't have to consider tubing compliance. And it says with respiratory acidosis, it can occur with a small tidal volume and an increase in dead space. Again, when you have an increase in dead space, the molecules are not getting to where they need to go. All right, so for example here, if I have an increased dead space, that just means I have a lot more air versus blood flow. All right, so the trachea has a lot of airflow, but very, very small blood flow. And the blood flow there is primarily capillaries. So you have this really large tube, that's your trachea, and then you have capillaries along the walls. Those are very, very small. So that would be an indication of an area of an increase in dead space. Okay, so if I have small tidal volumes, increase in dead space, respiratory acidosis could occur. I have respiratory alkalosis. So my PaCO2 is low and my pH is high. All right, so here our alveolar ventilation is too high, and we have to decrease the minute ventilation. Here's the thing. In respiratory alkalosis, you are hyperventilating. I'm going to say that again. In respiratory alkalosis, you are hyperventilating. You're breathing fast. You're blowing out the CO2. That's what's putting you in an alkalotic state. Now, why? It could be anxiety. It could be pain. It could be an inappropriate setting of your minute ventilation, or it could be because you are not oxygenating really well. And you've seen that a lot in the ABG, either in the quiz or you saw it in the homework. Metabolic acidosis. So here you have your normal PaCO2, so because it's not a respiratory issue. All right, so you have a decrease in pH, which causes the acidosis, and you have a decrease in bicarb and your base excess. So a decrease in bicarb, meaning there's hardly any bicarb in the blood. All right, so bicarb is not being produced. Okay, so therefore it creates a metabolic acidotic state. So in both of these, you got to manage underlying cause. Something is preventing the body from excreting our bicarb. All right, so we have to look at what's causing it. We have to support the ventilation based on what's happening. Here it says support ventilation if needed to increase our minute ventilation. All right, and we have to give them some bicarbonate administration. We can give bicarb. That's one of our emergency meds, if you guys remember your ACLS. So we can push bicarb, and that should help metabolic acidosis. But then in the same sense, we have to understand what the underlying cause is. So metabolic alkalosis, again, PaCO2 sitting at home because it is not a respiratory issue. Elevated pH causes your alkalosis, and your high bicarb. All right, and so it's triggering the metabolic. Now, in this scenario, there's a lot of bicarb in the blood. Okay, so again, something is causing our bicarb to be excreted out of the kidneys. Now, again, we have to manage whatever the cause is. Sometimes it's hypochloremia, low chlorine, hypokalemia secondary to GI loss. Now, this is going to be kind of big here. Hypokalemia, when you have low potassium, it affects your electroconduction of the heart. So with hypokalemia, when you look at an EKG strip, you might start seeing some PACs and PVCs because the heart is irritated. It's got less potassium. But here it says secondary to a GI loss. So I can possibly have a GI bleed, and I'm leaking out some potassium in my blood. All right, and so that is going to make it worse because now I'm losing fluid. If I'm losing blood, I'm losing fluid. And if I'm losing fluid, my blood pressure drops. If my blood pressure drops, my heart rate increases to compensate. My breathing increases to compensate. Because now I'm leaking out blood. I'm leaking out red blood cells, which has hemoglobin. So therefore, I'm losing binding sites for my oxygen to carry to my tissues. Now, if I can't control this GI bleed, then I'm going to go into polycythemia. I'm going to have to generate more. I'm going to be in a hypertensive state so I don't lose any more fluid. With my hypokalemia, I'm going to have irritations of the heart. So it's going to get complicated. That's all I'm saying. It's going to get complicated. So this right here is pretty huge. Diuretics or steroid administration. I might have too much diuretics. I might have CHF, and someone, the doctor, or let's say physician assistant or nurse practitioner, miscalculates, and they give me too much diuretic. I start losing fluid. All right. So then, therefore, I'm going to leak out a lot more bicarb because my kidneys are thinking, shoot, I don't have any more, I'm having less fluid. I gotta put some more bicarb out just to keep the acid-base balance. So therefore, I'm going to have a metabolic alkalotic state. So when you have this, you want to stop weaning at all. You want to make sure that you treat this metabolic alkalosis before you start to wean. Okay? So when we talk about FiO2, we have room air up to 100% at our disposal. We can restore the alveolar and our arterial oxygen pressure to normal. So if that's the case, it's because it's a VQ mismatch. And we've talked about that time and time again. I hope I just beat that into your brains. Okay? Because it's fixed, it's a VQ mismatch. If hypoxemia is caused by diffusion defect or shunts, we're going to need some PEEP. So PEEP, increase FiO2 and control of membrane permeability. What does that mean? That just means that the membranes should be clear enough for gas exchange. One example of a membrane permeability that is not conducive to gas exchange would be CHF. You have fluid in the lungs. Now, I can cross the membrane of the alveoli, but I cannot get to the surface and get blown out of the air because I got water. Okay, and a gas cannot diffuse in water. So once I push the fluid out via CPAP or BiPAP, then I can ventilate and oxygenate well. Hypoventilation-induced hypoxemia improves with mechanical ventilation as it increases alveolar ventilation. Okay, so if I'm just not breathing well, and since I'm hypoventilating, I'm getting less oxygen, definitely mechanical ventilation is going to help. Now, I don't know if this is due to shunt or neurological. If it's neurological, most likely mechanical ventilation will help. Now, when we want to assess the oxygenation of the patient, we have the PaO2. Is this the alveolar air equation. Well, you have the barometric pressure. So you have that equation. You also have your oxygen delivery, all that stuff. So now, if your oxygen delivery is decreased and it's caused by a low hemoglobin, then we got to transfuse. This slide says less than 7. In nursing, we were taught less than 8. But to me, 8 would be better because they still have enough blood, but yet I got to transfuse, so I'm going to give them more blood versus if it's negative. I mean, if it's at 7, you might start seeing some significant signs that they have a low RBCs. So if our decreased oxygen delivery is caused by a low pH SaO2, we're going to give them some oxygenation, and this is the way we fix oxygenation on mechanical ventilation. It's either the FiO2 or PEEP. If I have a decreased cardiac output, we got to make sure what's going on. We don't know what's happening, and then you give an inotropic drug or you repair what's going on. So if I have a decreased CO2, it could be possibly because I have an increase in PEEP. So to repair that, I have to decrease the PEEP to increase my cardiac output. Inotropic drugs. Inotropic means that it slows down the heart rate, but it increases the contractility of the heart, primarily the ventricles. It increases the contractility of the ventricles in the heart. So something like your digoxin would be an example of inotropic drugs. And usually when you give digoxin or digitalis, you have to do blood work in terms of the normal range, because you can have a therapeutic range and you can have a non-therapeutic range. And with that also too, you want to make sure that the ejection fraction in your echocardiogram is okay, because you don't want to give an inotropic drug when their heart is failing. When we talk about oxygenation, PEEP is something that we have at our disposal that is very good, but yet sometimes could be very bad. It helps maintain open and stabilized alveoli. It's required to decrease the shunt. So that's how we fix shunts, is through PEEP. Okay. Now we threw CPAP in here because CPAP is the same as PEEP, just depending on the machine. CPAP is used for your it's used only for oxygenation, and then PEEP is used when you have mechanical ventilation. So CPAP is non-invasive, PEEP is used more of an invasive. It increases your FRC and increasing surface area for gas exchange, because it opens up the majority, if not all, of your alveoli. And when you do have some shunting, you might have, let's say if it's a 50% shunt, let's just say for the sake of example, you have 50% of your alveoli that are closed and 50% of your alveoli that are open. That would give you a 50% shunt. So when you have PEEP going in, that can open up all the airways to the point where you might get 100% oxygenation. Okay, and so and that would increase your surface area, because now you've gotten from 50% to 100% of gas exchange going. And it also improves your arterial oxygenation. Again, PEEP is used for fixing oxygenation. Now you can't over-distend alveoli. In chapter 45, I showed you a picture of an over-distended alveoli or beaking, right? So that shows there's an overdistension in your alveoli. And when you do that, you can send some of the blood to poorly ventilated areas, worsening the shunt. So, I mean, just like how we can, positive pressure ventilation can push air into non-dependent areas, causing increase in VQ. This can, PEEP can cause a decrease in VQ, because they might send it to places where it's more, there's more blood flow and less air, and therefore, if you have that, then you'll be shunting a lot longer. So detrimental effects of PEEP. It can increase the incidences of barotrauma. Again, we can accidentally, right? We can accidentally over-distend the PEEP, causing some barotrauma. We can decrease venous return or cardiac output. Too much PEEP could squeeze the heart to the point we impede its physiology of contracting or relaxing. And last but not least, increased pulmonary vascular resistance. There is a resistance that we do have in our vasculature, and that kind of helps us with in terms of blood pressure. So if I increase the pulmonary vascular resistance, then I'm going to have to put more force into that resistance to overcome it and to have my blood flow where it needs to go. And so that's what's going to cause a little bit more hypertension, and that does still kind of affects our cardiac output. So I'm going to have high blood pressure and a decrease in cardiac output. So those are still parts of an impeded cardiac system. Factors that contribute to the development of auto PEEP: high expiratory airway resistance. All right, so you have a lot of gunk. You have a lot of phlegm in your airways that it causes your airflow from laminar flow to a turbulent flow, so therefore air gets trapped. Okay, and that still causes auto PEEP. And then an inadequate expiratory time. Again, if I have a longer inspiratory time and a shorter expiratory time, I'm not going to be able to breathe out that air so much that when I start breathing again, I have some air trapped, so therefore I will be auto PEEPing. So when we're talking about increased pressures, primarily our peak inspiratory pressure. That's the pressure necessary to overcome airway resistance and lung and chest wall compliance. Okay, so with peak inspiratory pressure, basically that's just the highest amount of pressure our lungs that are inside our lungs. And it's going to be the highest. So let me tell you this, when you get a plateau pressure, your plateau pressure will never be higher than your peak inspiratory pressure. Let me say that again. Your plateau pressure will never be higher than your peak inspiratory pressure. It's your peak inspiratory. It's the tallest. It's the highest. You have a mountain peak. That's the highest point of that mountain. So your peak inspiratory pressure is the highest amount of pressure that your lungs have. Okay. With PIP, it says also recruits alveoli but does not prevent them from collapsing. So with higher peak inspiratory pressures, you have pressures in your lung on inspiration. So therefore, it could splint some of these alveoli open. And then here's the airway resistance formula. You have PIP minus plateau divided by the flow. And again, in this particular flow, it's liters per second. All right. So we have, if you have the inspiratory hold and expiratory hold. All right, so our inspiratory hold will give us our static compliance. Static compliance is found by tidal volume divided by your plateau minus your PEEP. Okay, so again, you hold it for 0.5 to 2 seconds. On the Dragers, you have to time it, and you have to hold it for roughly around 3 seconds. The PB840s are great because you really don't have to hold it that long. You just push the button and it will calculate not just your plateau pressure, but it will also calculate your static compliance, which is great. That's something that I wish all ventilators had because we don't have time to calculate. You know, if I start doing my vent checks and I just press the inspiratory hold button and I get my static compliance, I can easily write that and then I can start trending to see if it's going up or going down. So for, let's see. So plateau pressure is always less than 28. So greater than 28 centimeters of water pressure, it increases the likelihood of causing lung injury. In your pill beams, it's going to say less than 30. 30 is a magic number. Here, Egan's is saying plateau pressure is less than 28. So 28 to 30. I like 30 because it's a round number, but on an exam, if you see plateau pressure is always less than what, put 28. Okay. Consequences of decreased resistance or compliance: less time to fill the lungs and empty the alveoli. That's the consequence of it. Because if you sit there and think about it, if I have a decreased resistance, all right, so if my airway resistance is decreasing, I have a lot more laminar flow. But if I have a decreased compliance, then it's going to be stiff, that it's going to be harder for me to empty out the alveoli. Okay. So with the decreased air resistance, since I have no phlegm, it's going to take me less time to empty. Right, and also here, if I have compliance, it's going to take me less time to fill the lungs because my lungs won't stretch. If either compliance decreases or your airway resistance increases, peak airway pressure will increase. All right, so if our compliance decreases, that means the lungs get stiff. The PIP, or your peak airway pressure, is going to be higher. So you're going to start seeing it as a trend goes higher and higher. Now with the compliance, it's going to take some time. In terms of airway resistance, it's going to be almost instantaneous. If a patient coughs, you're going to see your peak airway pressure going to rise. Your PIP's going to hit 65, 60, 62, and you're like, whoa. And when you look at the patient, you'll see them kind of shaking in the bed, because they're trying to cough. And you might even see some phlegm coming up either through the trach or the endotracheal tube. So once you see that, you know that they're clearing their airways because they had high airway resistance, because they were phlegmy. Right? So again, with air trapping occurs in lung units with high resistance and high compliance. So have a high airway resistance, meaning say there's a bunch of gunk. Right, it creates more of a turbulent flow rather than a laminar flow. Okay, and then if I have high compliance, meaning to say my lungs are really, really floppy, like emphysema, then air trapping, there's an increased chance that air trapping will occur. So we talk about mean airway pressure. That's the average pressure across the whole entire respiratory cycle. Any type of changes in terms of our PIP, tidal volume, it does change our mean airway pressure. Okay, so mean airway pressure is mostly tied to oxygenation, and then here I believe this is the box 46-1, factors that increase mean airway pressure. Actually, that's something different. Here, if you're looking at the waveform A, this is the constant. All right, you're looking at B, this is a little bit more sinusoidal. Oh gosh, it's kind of more like a sine wave, and then this is more of an ascending ramp. When you have a constant or a square waveform, then that is where you have more of the greatest mean airway pressure. Okay, it's because you have the longest inspiratory time. So here you're staying at this pressure for a long time, versus here and B and C, that this is why you have the highest mean airway pressure. Peak airway pressure, or PIP, peak inspiratory pressure on lung recruitment. Increase in PEEP recruits previously closed alveoli. So if you have a higher PIP, that does kind of help split open the alveoli. PEEP maintains them or keeps them open. All right, so PIP will get them open. PEEP will keep them open. Increased lung volumes and our tidal volume. So in pressure control ventilation, tidal volume varies, correct, because we are controlling pressure. Varies inversely with changes in static compliance and often airway resistance. All right, so because static compliance and airway resistance is since it's dealing more with pressures, right? Pressure is inversely related to volume. So that's where the statement comes in. Volume is inverse based on our pressures. Okay, so here's another way to take a look at it. If you had, if I'm on volume control and I start to inflate the lungs, okay, at beginning of inspiration, my pressure, there's a little bit of pressure in the lungs, but not so much. All right, and then let's just say my lungs are deflated. I don't have volume in there. Okay, I have a little bit, and that's where our FRC comes into play. So as I start to increase pressure, all right, then my lungs start inflating. Okay, so when my volumes increase, right, so I'm getting to the point where I'm going to be fully, I'm going to hit to the point where I can't breathe in anymore. All right, so I'm taking a big deep breath, and then right when I'm at that point where I can't take any more breath in, my volumes are high. So if my volumes are high, then my pressure is low because I don't have that pressure, or I can't add any more pressure to keep my volumes open. So what happens? It switches. So then as my volumes start to decrease, the pressure that's exerting out of my lungs starts to increase. Hopefully that helps. But it is volume and pressure are inversely related. Okay, so if you have a low volume, you're going to have high pressure. If you have a low pressure, you're going to have high volumes. That's what I'm trying to get at. All right, so normal spontaneous tidal volume, you're 5 to 7 mLs per kilogram, and this is more of ideal body weight. Our tidal volume recommended for COPDers. Now it increases to 6 to 8. Okay, remember they have floppy lungs. So you want to make sure our tidal volumes are a little larger to accommodate the floppy lungs. Now for our ARDS patients, remember they got stiff lungs. So my tidal volumes have to be lower. PillBeam says that normal tidal volume should be 6 to 8. For our COPDers, we maintain 6 to 8, and our ARDS is 4 to 6. That's PillBeams. Egan says for tidal volume here, it's 5 to 7, COPD 6 to 8, and ARDS is 4 to 8. So if we were taking an exam, stick with these numbers. Okay. So with lung mechanics, we also have functional residual capacity. So when we have our CPAP or PEEP, not positive pressure ventilation solely. All right. So prevent closure at an exhalation. All right. So basically what it's saying is that when you have if you're operating a CPAP or PEEP, okay, and it's not just positive pressure ventilation, that's going to increase your functional residual capacity, right? And it also depends on your PEEP level. If you have higher PEEP, that's going to increase your FRC much higher. Right? In restrictive diseases, as PEEP and FRC increase, lung compliance increases. So our static compliance increase, which is good. All right, and then until lung overdistension occurs, that is bad. Okay. So when we look at this graph right here, this is a pressure volume curve. So we start off, now these are just multiple plot points. So what we see here is if you start following from here, you start looking at, this is more of compliance. Right when you get to this part right here, it says less recruitment and overdistension. So this is where the alveoli max out. Then if I continue just to keep on adding more pressure, then it causes the beaking. Okay, here around this point it says less pressure required to maintain open but has greater tidal volume than inhalation. Now in PillBeams, it goes into depth about all of these lines. I have not studied these when I was a student. I did not see them on my board exam. I talked to Mr. Fuentes. He has not seen this in the board exam himself. And so therefore I'm not going to talk about all of these different lines, but I want you to know that there's a certain point in time where you start to over distend your alveoli. And also here, as you start increasing in pressure, right when you see a little bit more of a steep curve, this is where your alveolar recruitment comes into play. So imagine that you're at 0, you're adding pressure, 10, nothing. So it's starting to go up to 20. Right when you hit 20, you see that it, instead of just going straight out this way, it's a sharp increase. That is when you have your alveolar recruitment happening. Okay. So the pressure volume curve and lung recruitments in ARDS. So when you look at pressure volume curves, I talked about last lecture that it starts to look like it's, because the normal would kind of go diagonal, right? But if it starts to kind of drop this way to the right, it becomes more restricted. Why? Because remember, try to imagine that this is the y-axis, this is your volume, and then the x-axis is your pressure. So the more pressure I go towards the right, the higher it's going to get to the volume, but the volume is going to be low. Let me see here. Let's pretend this is the loop right here. So I have volume, I have pressure. So as I start to increase my pressure, let's just say I am right here, right, and my volume is 200. Guess what? This is where my loop would be. It would be at 20. And then it's at 300. So if I hit here, I hit around the 300, and then I would loop back. All right, so that'd be more restricted because it takes more pressure, but yet I have smaller volumes. All right, so that's where ARDS, that's how it's going to look like in a pressure volume loop. So again, with ARDS, lung recruitment or recruitment maneuver is useful. Normally we want to keep it open 40 to 50 centimeters of water pressure over 1 to 3 minutes. Okay, and then we want to maintain a driving pressure of less than or equal to 15 centimeters of water pressure. Now this is mostly talking about your lung recruitment or your recruitment maneuver. There are times where we're going to want to distend that alveoli, not over distend. We want to distend it for some time so that gas can exchange and we can blow out that CO2. Now again, with our ARDS patients, they have stiff lungs, so keeping that pressure there for 1 to 3 minutes, it's not going to hurt them, it's not going to kill them, but it's going to help them tremendously because they're able to ventilate. So here, if you have a tidal volume for patients in respiratory failure, again, we're going to keep it at 4 to 8 mLs per kilogram of body weight. So when we talk about decreased work of breathing, we're looking at making sure that the mechanical ventilator is set, right? And if it's set correctly, it should lessen work of breathing. Okay, the mode, the trigger, that's going to be important. Trigger meaning your sensitivity. Inspiratory flow and all need to be adjusted for comfort. Again, a continuum from full support AC to very little, which would be your CPAP. Now, one thing with decreased work of breathing. Let me see if it's on the other slide. Okay, one thing with work of breathing. It's not there. If you set, let's say, hypothetically, patient is on a PEEP of 5, and the patient is auto-PEEPing at 8. You would want to set your trigger or your sensitivity at -9. Let me think about that real quick. No, I'm sorry. I'm going the wrong way. You would want to set your sensitivity at -7. Here's why. If I have my sensitivity at -5, 1 or negative 2, they are auto-peeping at 8. They have to pull from plus 8 to 0, and then from 0 to negative 1. They have to increase that work of inspiration to trigger the ventilator. That is not comfortable, and that is going to increase the patient's work of breathing. If you set the trigger, okay, and the number, again, they're at plus 5 PEEP, they're auto-peeping at 8, so at plus 8 is where they are at right now in terms of their baseline. You will set the trigger to, hold on, let me think about this now. Yes, that's right. So you would set the trigger at 7. All right. So that's still equating to a difference of 1. 8 minus 7 is 1. So if you had it at negative 1, that's easy for the patient to trigger. Now, remember, this is falling under what is the patient's baseline. Baseline is plus 5 on PEEP, but they're auto-peeping at 8. So their baseline as of this moment is 8. So to correct that, to decrease the work of breathing, you'll set your sensitivity to 7. So when they take a breath, they're taking a negative 1 breath, and then the machine will kick in. That will correct their increased work of breathing. Now, to correct their auto PEEP, you will increase the flow on volume control. When you correct the flow, it should get rid of the auto PEEP, and the patient should go back to a baseline of plus 5. Now, when you correct the auto PEEP, please make sure you set the sensitivity back, because now their baseline has changed. So you want to change the sensitivity back to most likely on a plus 4, because they want to breathe just a little bit for the machine to trigger. So at a negative 1 and negative 2 from baseline. So if I'm at plus 5, I will set my trigger at plus 4 or plus 3. So therefore then when it hits one of those pressures, the machine will deliver the breath. Okay, so for work of breathing, and the patient is breath stacking, air trapping, auto peeping, whatever you want to call it, you want to set the sensitivity 1 to 2 centimeters of water pressure below that baseline. And that is why baseline is very important in mechanical ventilation, because not only do you see where they're supposed to return, you can also adjust for any type of situation where they have increased work of breathing. Okay. Here we go. Decreasing pressures. Okay. So when we have positive pressure ventilation and you have decreasing pressures, what we want to do is attempt to keep pressures as low as possible. All right. Especially when they have ARDS, any type of disease process that will stiffen the lungs. We want to control that pressure. Now our peak inspiratory pressure here says it's less than 40 centimeters of water pressure, and our plateau is less than negative 28. Again, I was saying that pill beam says actually it just says pressure in pill beams. They want it less than 30. Oops, where am I going? Okay, where did I go? Sorry guys. All right, here we go. So PIP of less than 40, I probably would say less than 30. Plateau pressure, just pretty simple, keep it at 30. But again, if you have an exam, PIP inspiratory pressure should be less than 40, and the plateau is less than 28. Another thing is you want to make sure that you have adequate humidity. You want to make sure that there is, number one, not so many secretions that increases airway resistance that will increase your peak inspiratory pressure. But you also want to make sure that they are not thick, tenacious, copious secretions. All right, you want to make sure that they are thin enough so that either the patient can cough it out or you can suction it out really easily. Bronchial hygiene, you want to make sure that again, there's no gunk in there, that they're able to cough up a lot of phlegm, that the phlegm is easy to remove, and if you need to, give some bronchodilators and some steroids to help decrease any type of inflammation. You might also have to decrease the tidal volume to keep the pressures low. Again, with pressure, you want to make sure that, yes, you want to control the pressure, but you want to make sure that tidal volume is also falling under the minute ventilation. High mean arterial, no, I'm sorry. Mean airway pressure, sorry. Whew. I thought it was mean arterial pressure. Sorry, mean airway pressure can impede venous return, reducing our cardiac output. Again, when you have so much pressure pushing on the heart, it's going to reduce your cardiac output. And just to reiterate, cardiac output is stroke volume times heart rate. So we talk about PEEP and CPAP. Again, these are used for improving oxygenation. If you have a ventilation issue, such as a pH of 7.19 and a PaCO2 of 81, PEEP is not going to help them unless they have an oxygenation issue. That blood gas is a ventilation issue. So if you have a ventilation issue, obviously you're not going to use CPAP and you're not going to manipulate the PEEP to fix any type of increased PaCO2. Right? I want to get that out of there. So improve oxygenation primarily with refractory hypoxemia. Refractory meaning to say hypoxemia that is not corrected by oxygen. Then another way to say refractory hypoxemia is a shunt, pulmonary shunt. All right, so if they're shunting, we need to splint that open, and if they have refractory hypoxemia, what's going to happen is that it's going to look like this. You're going to have less than 50 to 60, and your FiO2 is going to be greater than 0.5 or 50%. So you're going to crank up the percent oxygen, and your PaO2 is going to be either in the 50s and 60s. Now, let's stop and think here. What type of patient is going to be at a PaO2 of 50 and be okay? That is going to be your COPDers. All right, so knowing the history of the patient is going to be crucial as an RT, because you want to make sure if the patient is has COPD or does not have COPD, and that would help you determine if you need to be a little more passive in your treatments or you have to be more aggressive. Okay, so with PEEP or CPAP, it maintains open the alveoli, increasing FRC, reducing physiological shunt, often improving static compliance and a PF ratio. All right, so it does improve oxygenation in so many ways. Allows FiO2 to be reduced while maintaining a PaO2. So if you're cranking up your PEEP, most of the time you don't want to adjust your FiO2. If you had to, if you're weaning someone off oxygen, right, you would drop your PEEP first and then your FiO2, right, depending on the situation. All right, and we'll go over how to wean someone off PEEP later on. Okay, last but not least, if cardiac output decreases, intravenous fluid or inotropic drugs can be administered. All right, so in this case, if you dialed back your PEEP, all All right, because sometimes PEEP is going to decrease your cardiac output. But if your cardiac output decreases, a couple of things can happen. You could be losing fluid. You could go into shock, which is going to vasodilate you, which is going to drop your blood pressure, which is pretty scary because when you're in shock, you got to give large amounts of fluids. You got to give it through a bolus, and so therefore you're going to try to keep that blood pressure up there. Or you can use your inotropic drugs. Again, I mentioned digoxin or digitalis. That will slow down the heart, but also increase the ventricular contractility. So when we're talking about ventilatory patterns, we're talking about flow. All right. So when we have a square waveform, we said that is constant. A descending waveform, on the other hand, is where you have a high amount at the very beginning and then it starts to drop down. Okay, so in volume control ventilation, a descending waveform improves gas distribution. All right, descending waveform in a pressure control, what's going to happen is that it's going to show a decrease in PIP, plateau, work of breathing, dead space of tidal volume, decrease in carbon dioxide, increase in oxygen, and increase your mean airway pressure. So on pressure control, a decelerating waveform is going to do all of these things. So because, remember, with pressure control, we're controlling pressure. And so compared to a square waveform, you get a lot more. I don't want to say you get a lot more benefits, but these are the effects. I'm going to put it that way. These are the effects of a descending or decelerating waveform. So positive pressure ventilation, low flows can cause gas trapping and patient ventilatory asynchrony. We talked about this. If you have low flow, you will have a larger I time and therefore shorter E time, which will create a trapping event, and therefore the patient's not going to feel good. They're going to start to become asynchronous with the ventilator. Okay. Minimum risk with higher flows and shorter I times to allow more time for exhalation, therefore reducing air trapping. That is basically how we fix air trapping or auto PEEP. All right, we fix it by shortening the I time by increasing flow. Now this is on volume control. Okay, on pressure control, all we have to do is adjust the I time. That's it. Okay, inflation holds should be only done to measure plateau. Set holds can lead to asynchrony. So again, make sure you understand your ventilator. For example, the Draeger, you can press and hold that inspiratory hold button as long as you want. Actually, you have about 7 seconds until the machine will kick in. So that's a long time to have your breath on hold. So you want to make sure that for example, for the Draegers, you want to hold it for roughly around 3 seconds. But for the PB840, you just press the button and it will calculate your plateau pressure. So we've seen this again. Now again, if you want the highest amount of airway pressure, go with your constant waveform because it's remaining in that pressure for a longer period of time versus the sine wave, sinusoidal, I guess that's how you pronounce it, waveform, and your ramp flow. So when we look at the differences of volume control and pressure control, again, I'm gonna just reiterate this. When you're on volume control, you set the tidal volume, but the pressure varies. And when you're on pressure control, your pressure is set and your volume varies. Okay, that's very important because if you don't understand what mode you're in, you're not going to know what you're controlling. So on a CMV, or should I say assist control, all breaths are mandatory, which means the machine is doing all the work. All right, and they deliver the breath at the volume or pressure that you set. Your your time cycle is based on your respiratory rate, and inspiratory time is set based on you being in pressure control. So when we talk about volume control, continuous mandatory ventilation, VCCMV. Okay, so here we can control our minute ventilation. Okay, so we can make sure that the minute ventilation is therapeutic to the patient and the patient's condition. Volume is guaranteed, meaning to say that no matter what happens, if the machine triggers the breath or the patient triggers the breath, it is going to give the volume, that you set. But then our airway pressure varies, so depending on what's happening, and volume control, most likely volumes come in, but when you have an increased airway resistance, for example, your pressures are going to rise, and so that's where you're going to correct it by suctioning or giving bronchodilators or slapping the patient because they're biting on the tube. No, don't do that. Avoid setting a flow that fails to match patients' needs or exceeds their demands. Normally our initial flow setting is 40 to 60 liters per minute. You don't want to go, you can go higher than 60, but normally between 40 and 60 is okay. If you do 60 liters per minute, that's going to be 1 liter per second, so that's pretty fast. So if your total cycle time is, let's say, 4 seconds, and you put a flow of 60, that's going to give you an inspiratory time of 1 second. So that breath's going to get into the lungs really, really fast. And then you're going to have 3 seconds to blow out the remaining carbon dioxide. So again, in volume control, here's my flow. My flow starts to go on, and then pressure starts to rise. So when my flow starts, pressure starts to rise, my volume starts to rise, and then my pressure starts to rise as well. Okay, now with pressure, it is ascending. This is more ascending as well. And then when the pressure stops, the flow, or should I say the flow stops, it drops down to 0, then my pressure starts going down and my volume starts going down and my pressure starts going down. All right, so all of these three graphs are being recorded over time. Okay, so this is up to the minute breathing in terms of your volume, flow, and pressure. So again, set volume, set rate, and flow. Pressure varies upon lung mechanics. So depending what's going on, so for here, there's something happening, here's something happening, but our flow is constant here. And usually if you had it more flat, then the volumes would be constant as well. But here it looks like flow is constant, and then you have the ascending waveforms for pressure and volume. So when you have pressure control, continuous mandatory ventilation. Again, continuous mandatory ventilation, the machine is triggering the breath and it is cycling the breath, but pressure is being set and volume is varying. Okay, so when we have constant inspiratory pressure, so we have a more even distribution of ventilation. Why? Because the pressure is constant. And when the pressure is constant, it's going to show that it has a constant waveform, which is the square waveform. And when you have pressure and a square waveform, that means that is the highest amount of mean airway pressure that the lungs are going to get. Okay, again, volume varies. Inspiratory flow is not a parameter. On pressure control, it's going to be I time, not flow. So here is pressure control. Now here, when you look at pressure that's starting to rise, it starts to somewhat reach a plateau here. Okay, it's not so much of a square. It doesn't shoot up. Remember, pressure has to start ramping up. All right, so this would be somewhat of a ascending waveform, but it almost seems like it can be a square, but you just have this rounded area and then it kind of levels off here. So I guess when you're looking at the leveling off, this would be more pressure control, because when you look at the others, there's no square waveform here. There's really no square waveform here. This is the closest to square it can get. So if I looked at this on an exam, I would think that we were in pressure control, because this looks more like a square rather than the other two. So when pressure starts to go up, you start noticing the volume starting to rise, and then your pressures, they start going up, and then I'm sorry, this is your flow. The flow starts going up, but then it starts to kind of go down, and then right when the pressure stops, the pressure starts dropping, flow drops. So this is you exhaling, and then your volumes are starting to go down as you exhale. So when the lung compliance increases, your tidal volume will increase. And I want you to remember that, because we're trained to look at abnormalities. So we are trained to look at either an increase airway resistance or a decrease in lung compliance. So again, if you have an exam question where the tidal volume is getting better, then that means your static compliance is increasing, which is a good thing. That means the patient is getting better. So when we're on intermittent mandatory ventilation, now intermittent meaning to say that it's intermittent between the patient and the machine. So sometimes the machine will breathe, sometimes the patient will breathe. Okay, so IMV allows or requires the patient to sustain some work of breathing. Now some people think that the IMV is a weaning mode, and I would say that is true up to a certain point. If I have a patient that is they need mechanical ventilation, but they're still awake and alert and oriented, I might put them on SIMV as a starting mode. Now if I start a patient on SIMV, I cannot call that a weaning mode, because weaning mode is a mode that you would take the patient down to a lower level of ventilatory support. Here's what I mean. If I had the patient on SIMV and I bring them down to BiPAP, BiPAP would be the weaning mode for that particular patient. If I set the patient on AC and I switch them down to SIMV, then SIMV would be the weaning mode. Capiche? So I don't want you to automatically think SIMV is the weaning mode. No, that would be incorrect. So and the reason why the people say that SIMV is a weaning mode is because the majority of the times we start the patient on CMV, or should I say assist control. And since we stick the majority of the patients on assist control and we drop them down to SIMV, that's why we call SIMV a weaning mode. I want you guys to think that it depends on what mode we started the patient on. Okay, so again, with intermittent ventilator ventilation, it can be partial support. Now, partial ventilator support normally starts when you have a respiratory rate less than 8. Okay, respiratory rate less than 8, then we are partial support. Okay, so if it's greater than 8, then it would be full ventilatory support. Now that's per pill beams. All right, so just letting you know that there's a partial and there's a full ventilatory support. AC mode is full ventilatory support regardless. Yeah, because you're not going to set a respiratory rate of 8 on AC unless you have a really large tidal volume that would equal out your minute ventilation, which probably won't happen. So that's why we don't put, we say that AC mode is full ventilatory support. Okay, so mandatory breaths are delivered at a set rate. So we do have what we call a backup rate here. So if the patient is not breathing let's say every one breath every 6 seconds, the machine will kick in. All right. Between the mandatory breaths, the patient can breathe spontaneously at his or her own tidal volume and rate. So that's where the synchronization comes into play. So if they breathe in, let's say at second number 5, on the 5th second, when they're supposed to breathe at the 6th, then it will adjust based on the patient's last breath. All right, so that's the good thing about IMV when it's synchronized. Okay. All right, so if we're volume control IMV, same thing applies. We just control the ventilation, or we control the volume. All right, and so we control volume, and that's going to depend on the machine giving the breath. It doesn't deal with the patient breathing their own breath. So if I have a set rate, if I have the patient on VC IMV, I have a set rate of 12, which gives me a total cycle time of 5. So 5 seconds per one breath. If I breathe myself, I might have a tidal volume of, let's say, 300. But if the machine gives me the breath, then I will breathe 500 mLs. All right, so that's where you have VC IMV, but that's without pressure support. Without the pressure support, my tidal volume that I spontaneously breathe is what it is. So even if I'm at 127 mLs, that's my tidal volume by myself. And if you start seeing that on the patients, you know that that is not adequate volume, therefore it's not going to be an adequate ventilation. So what you would do to correct it was that you would add pressure support. All right, so patients with neuromuscular diseases, especially Guillain-Barré's, during crisis, patient is unable to sustain minute ventilation and tidal volume. This is where your bedside parameters come into play. You're going to check your NIF, your MIP, your vital capacity. You're going to check those to assess respiratory muscle strength. If you see the strength starting to decrease, that means the paralysis of these neuromuscular diseases are affecting the respiratory drive. Therefore, that's where you would have to adjust your strategy for this particular patient. Pressure control, IMV. Same thing. Patient's able to breathe on their own. The vent's going to synchronize the breathing, and we are controlling pressure instead of volume. So if we're controlling pressure, we have the luxury of setting the I time instead of flow. And when you're talking about total cycle time, IE ratio, things of that nature. It says PCIMV is indicated when preservation of the patient's spontaneous efforts is important and patient-ventilator synchrony is a concern. Okay, we have premature infants with respiratory distress, non-compliant lungs, compliant chest wall, and poor respiratory effort. Again, when you have a lot of babies, neonates, you're going to put them on pressure control. The lungs are very, very delicate. You can blow them out really easily if you put them on volume control. So with our babies, we like to put them on pressure control. Here, in this particular scenario, the premature infant has compliant chest wall, right, and poor respiratory effort. So the thing is that it's a non-compliant lung. When you have a non-compliant lung, automatically switch them to pressure control, please, because you're going to give them a pneumo. You put them on pressure control here, and they can breathe even though the respiratory effort is poor. You can give some pressure support, or you can try to remember they just came out, right? They're premature, they're infants. You want to increase their respiratory efforts. You want to strengthen the diaphragm. So for whatever reason, depending on the prematurity, they may have premature nervous system. That's probably why it's not triggering the diaphragm to drop and to increase the negative pressure that it takes to breathe. So we put them on IMV so that they can strengthen the muscles, but if they fail, then we have the backup rate to kick in to help the little guys breathe. Okay. So again, this is can breathe spontaneously between set parameters. BiPAP. BiPAP is used for a couple of things. Number one, nocturnal ventilatory support or chronic disease patients. It can be used at night. There are times in the hospital setting you will see a order saying CPAP at night or BiPAP at night. So when you see those, it's probably because they have either obstructive sleep apnea or central sleep apnea. Now, in BiPAP here on the slide, nocturnal ventilatory support of chronic disease patients, we're looking at primarily more COPD, but the sleep apnea that you will treat with BiPAP is central sleep apnea. The reason why you want BiPAP is because of the set respiratory rate. We have a backup rate on BiPAP which we do not have on CPAP. CPAP, you have to be spontaneously breathing. If you have central sleep apnea, your brain or your spinal cord, wherever your nerves are coming from the brain to your diaphragm, are not working. The telephone line is not connecting. So therefore, you don't breathe. So if you don't breathe and you're on CPAP, guess what? The CPAP ain't helping. Right? So when you have them on BiPAP and you are not breathing, you have an event of apnea. Your respiratory rate that you put in the BiPAP is going to kick in due to this total cycle time. So the machine is going to say, hey, look, Bob is supposed to breathe every 6 seconds. Bob didn't breathe. I better breathe for him. That's the beauty of our backup rates, because if the patients can't breathe, we can breathe for them. So in central sleep apnea, use BiPAP. Now for the last one here, treatment of obstructive sleep apnea, that would be more of your CPAP instead of BiPAP. So CPAP would be the one used for obstructive sleep apnea. Patient is spontaneously breathing, but the tongue is slipping back towards the back of the throat, causing a decrease or a narrowing of the airway. So therefore the gas exchange would be less. So we give them CPAP to splint the tongue out of the way of the airways, and so therefore it would increase gas exchange. Now, let me say this. BiPAP is it falls under ventilation. BiPAP falls under ventilation. CPAP falls under oxygenation. If you have a ventilation issue based on your blood gas, you will use BiPAP because that is a form of ventilation. It's a ventilator mode that affects ventilation. If you have an oxygenation issue, you will use CPAP. Obstructive sleep apnea is an oxygenation issue. You wake up less oxygenated, you have headaches, you have hypersomnolence. During the day you get sleepy, you want to sleep. Why? Because you have low oxygenation. That is why you would want to use CPAP. Okay, I want to drive this into your heads, because when you're taking an exam and you see that it is not a ventilation issue, it's an oxygenation issue, guess what? You're gonna cross off all of the answers that say ventilation. If I give you ACVC, you're crossing that out because you don't need mechanical ventilation. If I give you BiPAP, you're going to cross it out. You don't need ventilation. If I give you some other mode, you're going to cross it out because you don't need ventilation. Why? Because the blood gas says there's an oxygenation issue. So that's going to be one way for you to weed out the wrong answers, because you have to know if it's a ventilation or oxygenation issue. CPAP. Now this is where the obstructive sleep apnea should fall under, and I'll probably fix the slide. Again, spontaneous breathing. You need to be spontaneously breathing to recommend CPAP. Please don't put CPAP on someone who is sedated. Don't do it. They are spontaneously breathing, yes, but with sedation, they are breathing less. And this is not going to help them breathe even more. If I put someone who's on sedation and I happen to have to put them on a non-invasive ventilation mode, I will use BiPAP, because if someone over-sedated a patient, or they're still in the post-anesthesia care unit, and they over-sedated the patient's respiratory drive drops. So all of a sudden, they're breathing at a rate of 12, then it goes to 10, then it goes to 8, 6, then they're gasping. And I had to use some form of ventilation. I will slap them on BiPAP. Why? Because I have a backup respiratory rate. So if they fail to breathe or they're breathing slower, guess what? My backup rate will get them to breathe at whatever I set it to. So if they're breathing down at 6 breaths per minute, I'm going to switch that out. I'm going to give them 12 breaths per minute, 15 breaths per minute, right? So that I can increase that minute ventilation for them so that they can breathe better. All right, so for CPAP, CPAP is spontaneous. You can alveoli are maintained open, and so you have better gas exchange. FiO2 needed to maintain adequate PaO2 may decrease. So for CPAP, you're going to have only one pressure, and that's going to depend what it is. It might be just +5, right? So you have +5 going into the airways. You're going to have +5 remaining in your lungs when you're done exhaling. Okay. May reduce need of high FiO2, reduce shunt, increase VQ, correct. Maintains alveoli at greater inflation volumes. Okay. It holds airway pressure essentially constant. That is correct, because we have a constant pressure, right? So if I have a constant pressure, guess what? If I had to graphically look at it, it's going to have a square waveform, which square waveform would increase mean airway pressure. It has side effects similar to those of positive pressure ventilation. Again, if I have CPAP, it's going to start pushing air into lung spaces that may be non-dependent or independent, so therefore it can screw up my my VQ ratio. So if I have someone on CPAP, it doesn't provide ventilation. Again, it's only used for oxygenation. Patient trigger and cycled. Why? Because you need to be spontaneously breathing. And last but not least, volume depends on patient's effort and lung mechanics. Correct. So if it's all about spontaneously breathing. So what the machine is doing is just looking at how the patient is breathing. All right. So this is how it looks like with someone on CPAP. Volumes vary depending on the patient's ability to draw in breath. The flows are different because it depends on how the patient is flowing. And then our pressures, you see it kind of jaggy, but it comes back to a certain point. So it looks like they have a CPAP of +5, because that seems like that's where it's going to. All right, so when we talk about pressure support ventilation, now it says PIP minus plat on the side, and that is going to be let's kind of see what's going on here. Patient triggered, okay. pressure limited, okay, because we are in the pressure support, and flow cycled. So again, patient triggered, patient starts the breath, pressure limited. There is a control. We're setting the pressure, so it's limited to what we set, and flow cycle, meaning to say if the flow stops, it's going to end the inspiratory phase of the cycle. All right, so flow cycle may be factory preset or adjustable. So depending on your machine, most likely your ventilator, it could be the flow cycle here could be a factory default setting. Minimal levels set to overcome airway resistance caused by endotracheal tube secretions, bronchospasms, impose work of breathing. All right, so again, when I talk about pressure support, it's only dealing with inspiration. Okay, so here, when we look at patient has control over their tidal volume, their I time flow, and their respiratory rate. Again, we're not really setting anything here. We're just setting a pressure to help the patient reach a tidal volume that is conducive to an appropriate minute ventilation. That's what pressure support is. All right. Okay, so here, tidal volume is determined by pressure support level. When we start looking at this, we start looking at BiPAP. And BiPAP, the difference between the IPAP and EPAP, and I'll have to go over this with you guys in lab later on. The difference between your inspiratory positive airway pressure, your IPAP, and your EPAP, which is your expiratory positive airway pressure. And to keep things in the same context, EPAP is the same as PEEP, is the same as CPAP. All right. So for bi-level, we use EPAP for an end pressure, end positive pressure. Okay. So again, when you use the word EPAP, I'm already thinking you're talking about the patient on a bi-level ventilator or BiPAP. All right, so remember, use those correctly. Don't say IPAP is, because if you say IPAP is 12, EPAP is 5, I'm thinking you're talking about a patient on BiPAP. If you use peak inspiratory pressure or PIP and you use PEEP, I'm thinking you're talking about a mechanical ventilator, okay? An invasive mechanical ventilator. Okay, so depending on what you say to me, it's going to tell me what you're talking about. This time we're talking about BiPAP. BiPAP has a pressure support. So the difference between the IPAP and EPAP is your pressure support, and your pressure support determines your tidal volume. Okay, so the difference of your IPAP and EPAP which is your pressure support in BiPAP mode, it will determine your tidal volume. Okay, I just want to put that out there because that's what the slide is saying, but we haven't delved into BiPAP so much, so when we do, I'll reiterate this concept later on. Okay. Pressure support may decrease respiratory rate, work of breathing, VO2, and increase tidal volume, and that's going to be based on how well you generate tidal volume spontaneously. All right, so if I got switched from AC to SIMV and I'm breathing with my diaphragm for, let's say, the first time, my tidal volume is going to be low. Why? Because my diaphragm muscle is going to be weak. So as the nerve innervates the muscle, it may not innervate it very well or very little, right? Because maybe I was sedated all that time when I was in AC. So I went on a sedation vacation. They saw that I was breathing better, so they switched me to SIMV. Well, my tidal volumes are probably going to be low. So that's where I'm going to need a pressure support to maintain that. So I'm getting a workout with my diaphragm. My neurons are firing to the point where it's going to contract the diaphragm in a manner that either I was at before I was sick and got intubated, or at a better tidal volume than when I was starting to breathe on my own. So if a couple of days have happened, or a couple of days have passed by, and my tidal volume has been increasing, that's probably because either neurological pathways are becoming better and it's innervating the diaphragm much better, or I'm having stronger contractility because my muscles are getting much more firm and toned. All right. Patients prefer like this because it's comfortable. You're getting more volume. When you get better volumes, that affects your minute ventilation. Okay? So when bedside worker breathing measures are unavailable, adjust the level of pressure support to a spontaneous rate of 20, which falls under our normal, and our tidal volume of 6, which falls under normal. So basically, what I'm trying to say here is that you would have to, if you have nothing available, or the bedside worker breathing measures are unavailable, so I can't determine your bedside parameters based on your worker breathing. So what I have to do is I just have to increase your respiratory rate and get your tidal volume to 6 mLs per kilogram of ideal body weight. All right, so 20 is kind of fast, but that helps kind of blow out the CO2. And then on top of that, I have my tidal volumes set, so I should be stabilizing my minute ventilation. Primary uses of pressure support is to augment patient spontaneous tidal volume. If I'm breathing 150, you give me a pressure support of 10, I might jump my volumes up to like 350 to 400, and that's going to make me feel better. Overcoming imposed workup breathing. Again, if I'm having difficulty breathing, you give me pressure support that might help inflate my lungs even more, and so therefore that would decrease my workup breathing. So here's a mode that I really haven't seen out in the field. I know some of you guys, I showed PRV on the Draeger, and that is your airway pressure release ventilation. This one is your pressure regulated volume control. Now, based on this, this is actually pretty cool. It's based on pressure control ventilation. So I'm controlling pressure here. Okay. But it says the ventilator attempts to maintain a target tidal volume by adjusting the pressure. And that's basically what we have to do manually on pressure control. So if I set a pressure of 20 and I'm hitting tidal volumes of 300, but I want 400, I have to start kind of playing with the pressures. So if I'm at 20, I might have to go 22, 24, 26. And so then right when it gets to that tidal volume I want, then I'll stop. Here, this is automatically calculating. You set the. I'm not sure if you set the target tidal volume, and then you set the, and then you are controlling the pressure. But it looks like, based on what the target tidal volume is the pressure level will start to adjust. This is based on previous breath. So if I trigger a breath and I get a tidal volume of 250, but I want 500, so the next breath, the ventilator is going to adjust the pressure and see if that's going to help. So the machine's going to do it for me. It's not going to be me doing it manually like the PB840 and the Draegers. This particular mode, it's gonna, based on what volume I want, it's gonna adjust the pressure per every breath, which is really, really good. Delivered over a course of several breaths without reaching max pressure. Adjustments are 1 to 3 centimeters in increments per breath, which is good. It's nice and slow, and it'll adjust the pressure to get that set tidal volume. So we don't have to mess around. We don't have to try to control what's going on, even if there might be some type of lung issue based on the disease process, the machine will adjust. Okay, so I think this is pretty cool. I haven't seen it in action. I haven't seen it in the field, but based on what I'm reading and what I've heard other people talk about, they like this mode. All right, now let's go into positioning to optimize oxygenation. Now, you guys studied in 210 postural drainage. All right, now this is more postural oxygenation. Okay, so when you have patients in bed all the time, as nurses, we had to frequently turn them because we wanted to avoid pressure ulcers, pressure sores. Okay, but in the same sense, when we're doing this too, we're avoiding atelectasis and hypoxemia, which as a nurse I didn't know. I just wanted to I just want to prevent any type of pressure sores. But we do also prevent atelectasis and hypoxemia, and also some secretion retention. Okay. Kinetic beds, I haven't seen one, but I've seen some beds where it can turn patients automatically. I think that'd be great. But the problem is if the patient is either heavy set or they move around a lot, a little bit agitated, they might kind of hurt themselves. They might fight the turn of the bed. So hence it's kind of controversial. Kinetic beds, I'm not sure. There are some that go upside down. There's some that go upside down, meaning to say it flips the patient prone, and you start seeing that with ARDS, which we'll talk about later on in the slide. Unilateral lung diseases, there might be one side that might be messed up. So here's what you do. You place the good lung down as much as possible. So if my right side is the one that is diseased, right? And based on this, you want to put the good, you're going to roll me to my left, because my left is the good one and I got the disease on my right. Okay. So again, it improves our VQ ratio and oxygenation. The only thing I can think of is that it's pooling a lot of the usually if it's a disease process, you might have a lot of infectious pus. You might have a lot of secretions, and as you turn your body, it might start pulling the secretions away from the alveoli, so you're going to have improved oxygenation. Last but not least, your ARDS patients. When you put them on prone, the oxygenation goes up, which is strange. And in ProBeams, they say they don't know why, but it does, so they go with it. So what you can do with them, you can use a kinetic bed to flip them upside down, or should I say flip them on their stomach so they're prone. And with that, it says patients with a PF ratio less than 100 were the group most likely to benefit with prone positioning. So PF ratio of less than 100, they like that. If you had a patient who was roughly at 75, you turn them prone because they had ARDS, and now you have them at 85. You can still continue to give supplemental oxygen. You can put a nasal cannula on them just to increase that 85% to roughly around 90, 92. If you put the patient in a position that's going to improve oxygenation and they're kind of capped at a certain SpO2, why not put on a nasal cannula? Crank that sucker up. Make sure that they are breathing and oxygenating really, really well, because remember, the oxygen goes into the tissues, and it goes into the tissues for healing. So there might be some issues that they may have that's compounding the ARDS, like pneumonia, and that can help the body fight the infection along with antibiotics as well as the oxygen. So right here, some cardiovascular effects of our positive pressure mechanical ventilation. So it says greater in, looks like that tells me plateau pressure leads to an increase in plateau pressure, leads to increase in CVP, which is the right atria. Central venous pressure and hemodynamics, it's measuring our right atrium. Now again, Pilbeam's introduces hemodynamics in chapter 11. For some reason, Egan's is introducing or showing some hemodynamics here, which is going to throw you off. But suffice it to say that you can have a decreased venous return and decreased ventricular stroke volume. Now, I had said that the cardiac output is the combination of stroke volume and heart rate. Stroke volume and heart rate. So if you have a decreased stroke volume and you have a decreased return, especially with your stroke volume, that's going to affect your cardiac output. All right, so venous return is impeded and right ventricular preload and stroke volume are decreased, which then leads to decreased blood flow, which is our cardiac output. That's correct. All right, so if we're having here, this is normal. Here, this is a narrowing of your vena cava because of all this pressure. So therefore, with all this pressure, you have less blood flow. Less blood flow will lead to less stroke volume, which leads to a decrease in cardiac output. That's basically what this is saying. All right, so when we're talking about mean airway pressure, it is determined by time volume, respiratory rate, I time, any type of inspiratory pause, E time, IE ratio, PIP, PEEP, and inspiratory flow pattern. Holy cow. That is basically everything. Right? So, changes of above to decrease our mean airway pressure. So if our PaO2 is high, you drop the PEEP. That's easy. Follow carefully to avoid desaturation. All right. So if we have high PaO2, I'm thinking like 120, 130. We're going to drop PEEP. All right. We drop PEEP first, and then we drop our FiO2. Okay. All right. So if my compliance is increasing, so let's say I was first stage of ARDS, and I was able, or should I say the medical staff was able to get rid of the pneumonia, get rid of the bacteria that's causing the ARDS before it can damage the alveolar membrane and cause it to have a lot of hyaline and fibrous tissue, and we have an increased compliance, then we can just deal with the PEEP and any type of diuretics. Now, that's kind of interesting because when I have increased compliance, that means my lungs are able to expand more. All right. So with PEEP and some diuretics, that can increase compliance. That's what that's telling me. I'm not sure. It depends on the disease process, in my opinion, because if I have an increased compliance due to CHF, yes, I can see diuretics and PEEP coming into play. Here it's just saying that it's just an increased compliance. I'm not sure what the disease process is, so I'm just going to put this one on. I'm going to chalk it up to CHF. Decreased tidal volume or pressure control level. That could decrease your mean airway pressure. You decrease your I time and IE ratio. And also changing from AC to SIMV or pressure support ventilation. I can see that because you do have variances of volumes. I'm sorry, if you... Yeah, because patient can breathe, so therefore it's varying volumes and varying pressures. Now here it doesn't tell me if it's pressure control or volume control. So if we're talking about airway pressures, then if I'm switching from AC to SIMV in terms of pressure control, I can understand. So and I think that's basically what's happening here, depending on what's going on with the patient and a type of pressure control situation, because we are trying to decrease mean airway pressure. So if we want to minimize the cardiovascular effects, okay, fluid management and cardiac output. Basically, the circulatory system is about plumbing. Do we have enough water? Right? Our water in the pipes is our blood. Okay, our pipes depends on the direction the pipes are going. If the pipes are going away from the house, that is our arteries. If my pipes are coming to the heart, or should I say to the house, those are coming to the heart, that is your veins. All right, so here's the thing. When we talk about fluid management, we're talking about a decrease in cardiac output because of, again, if we have a massive laceration and or an artery is severed due to trauma and I'm bleeding out, I'm losing fluid. So that's going to drop my blood pressure. And if that's the case, I'm going to hang some normal saline, right? And because that is a isotonic solution, it's not going to pull fluid away, or it's going to pull fluid into the circulatory system. It's neutral. So I'm going to give 1,000 mLs of normal saline. I'm going to run a bolus of 500 mLs just so that the body can replace all that fluid that it lost. Okay, so I want you to think, if you have cardiac output issues and it's decreasing, it could be due to volume, hypovolemic, or it could be due to shock. It could be due to anything that would vasodilate your patient. That's going to cause a decrease in cardiac output. In terms of sepsis is huge. Sepsis doesn't happen suddenly, because when you have septicemia and it gets bad, it becomes sepsis. So you become septic. It's in your blood. Now this bacteria in the blood can circulate anywhere. That's what makes it dangerous. It can cause multi-organ failure. As it gets worse, so you have sepsis, and then it turns into septic shock. The bacteria messes your body up so much that you automatically vasodilate. And when you vasodilate, you drop in your cardiac output, so therefore your blood pressure drops. That's what we got to replace. We got to give more fluid to fill up the vessels that have vasodilated, so that we can increase that blood pressure back to normal. So when you're facing with sepsis, you have high PEEP and high mean airway pressure. Your preload in terms of your cardiac output may decrease, thus worsening your oxygen delivery. Okay, here's the thing. Because you have bacteria in your blood, and you have a lot of white blood cells going after it, you will have a decreased cardiac output. When you have decreased cardiac output, you have less blood flow. You have less blood flow. You have less red blood cells. You have less red blood cells. You have less hemoglobin, less binding sites for the oxygen. Therefore, you have a decrease in your oxygen delivery. Fluid and blood administration to maintain CO. So again, you have hypovolemia, or you have hypovolemia, and you have. There's another type of shock that you have blood loss, but the whole point is that we got to replace the fluids. All right. Ooh, sorry. Pharmacologic maintenance. So, drugs. What kind of drugs can we give? First line is fluid administration. Obviously, if we are decreasing in cardiac output, we are decreasing in fluids or blood, we got to replace them. Now, here's the thing, except for CHF. Why? Because since we have some congestive heart failure, we have a lot of fluid backed up. So if we have a lot of fluid backed up, we don't want to give more fluid. Okay? Or if the fluid we want to give, it would be a hypertonic solution. So it's going to pull fluid away from the circulatory system. It's going to put it into, it's going to pull fluid out of the cellular area and the tissues, and it's going to put it into circulation, where it's going to go and get filtered into the kidneys, and then it will be filtered out through your urinary system. Okay. Inotropic therapy for decreased myocardial contractility. Now, we talked about this time and time again. I'm so used to giving digitalis to patients, but you have dopamine, amiodarone, and epi that can also give an inotropic effect to the patient. Again, we're talking about patients with decreased myocardial contractility. All of these medications is going to increase the contractility of the heart, making the ventricles contract stronger, so that it would increase your cardiac output. Vasodilators and diuretics to control fluid overload. And now we're talking about CHF here. So with our CHF patients, they have so much fluid, you want to vasodilate, because the more fluid you have and you're constricted, that's going to increase pressure. That's going to give you more hypertension. So we want to vasodilate because they have so much fluid. And we want to give a diuretic so they can pee the fluid out. So therefore, they would not be puffy, they would not retain fluid, and the heart would not be taxed with a lot of work. Now you have your nitroprusside, Cialis, nitrous oxide, your iloprost, and then your Lasix, which people pretty much are well familiar with Lasix. With increased intracranial pressure, we want to be careful with those types of patients on mechanical ventilation. We want to make sure that it says the perfusion of the brain is quantified by the cerebral perfusion pressure. What's normal about that is 80 to 85. I have not seen a cerebral perfusion pressure being calculated on the vent. We just want to make sure that there is no effects on vitals based on intracranial pressure. We do have some ICP monitoring in the ICU that's more directly the intracranial pressure. If this cerebral perfusion pressure decreases, your cerebral blood flow decreases. Okay, and so when that happens, you have some cerebral ischemia and a decrease in cerebral O2 metabolism. The cerebral ischemia is going to be pretty much an issue because you have lack of blood flow, lack of oxygen, hence you're going to have an anoxic event. So different parts of the body is going to be affected as well when you're on mechanical ventilation. So for this particular example, we have a patient with closed hedge injury, severe traumatic brain injury. And so acute hyperventilation can control ICP until the pressure returns to baseline. So if our ICP starts increasing, we want to hyperventilate. Why? Because CO2 increases intracranial pressure. That is why we need to hyperventilate the patient sometimes when the ICP starts to rise, so that we can blow off the CO2 to decrease the ICP. So once that happens, then we put them back on normal ventilation, the normal vent settings. Hyperventilation can be avoided after traumatic brain injury. Other methods can be employed to decrease elevated ICP. All right. So, for example, if I have so when I hyperventilate the patient, I have to be cognizant of a couple of things. Number one, the increased cerebral vascular resistance. So if I increase my cerebral vascular resistance, it's gonna take more pressure to circulate through the cerebral vasculature because I've increased that resistance. So therefore, I'm going to have to increase the work. And so therefore, when I increase work on the cerebral vasculature, that's going to increase pressure. And also, it also increases intracranial pressure when I hyperventilate. So I don't want to hyperventilate too much. That's why here, right when the ICP is controlled, then I bring it down. Okay. Now here's the thing. Hyperventilation increases intracranial pressure, but I can also control intracranial pressure. So here's the thing. It's going to depend on your CO2. That's it. So my hyperventilation can mess up the patient if my CO2 is either it's really high and I'm trying to blow it off, and it might start to increase. But if my CO2 is low in the true sense of hyperventilation, it could possibly control my ICP. Intubation should be attempted only after the patient has been sedated. Again, we don't want to try to intubate the patient if they're not sedated. They're going to be anxious. It's going to drive up the ICP even more. Again, our intracranial pressure should be maintained at less than 20 millimeters of mercury. So that's very small pressure. Now, the reason why we have small pressure is because our skull is not expandable. So if I have any type of pressure increase inside the brain, there is no way to alleviate that. That's why sometimes the doctors have to drill holes in the skull to let out fluid to decrease intracranial pressure. And so that's why you'll have some type of cerebral shunt. So we can collect fluid from it. It's a piece of the neurosurgeons are going to put it in on the skull, and it's kind of like a tube that's sticking out of the head, and it's a really small tube, and we can kind of clamp it, and it kind of blends with hair, so aesthetically it's not going to be appalling for the patient, but it's there, and we can drain some intracranial pressure or intracranial fluid if the pressure is starting to increase. So, arterial pressure is calculated so that you have 2 times the diastolic plus systolic divided by 3. So, therefore, there's 2 numbers plus the systolic. It gives you 3 numbers. Now, a normal mean arterial pressure is 93 if the arterial pressure is 120/80. Okay, so, blood pressure is normal, then your mean arterial pressure is 93. A decrease can be caused by shock, because that's vasodilation. High PEEP, because that is decreased cardiac output. And high mean airway pressure. All right, so those 3 kind of decreases your mean arterial pressure. Now, here's a couple other body functions that are affected. You have your renal function. Positive pressure ventilation increases ADH, antidiuretic hormone, and natriuretic hormone, and these hormones cause fluid retention. So with increase of these hormones, you'll cause some fluid retention. So when you start looking at patients hypothetically in a subacute, they're going to look like they are retaining a lot of fluid. It might be CHF. It may be because of positive pressure ventilation that is affecting the renal function. Also, too, most likely a lot of your subacute patients will be on Foley catheters, or shall we say indwelling catheters, and they're going to be collecting a lot of urine because of this fluid retention. Liver is being affected. It's going to have decreased perfusion, which is liver function decrease. I think in one of the slides it said something about the hepatic portal being dilated, and that is based on this decreased perfusion. Okay. Last but not least, we have a GI function, a lot of stress, ulcers, ischemia, and some distension. Remember, if I overinflate the patient's lungs, like in your BLS, when you're bagging pretty fast, all right, then sometimes the air will escape into the stomach, causing distension. So that's why with positive pressure ventilation, remember, it's equal opportunity. The pressure is going to go everywhere. It may go into the lungs. It may leak out into the stomach to cause some distension. And then you're going to have some stress ulcers in the GI causing some as a cause of some type of ischemia. So also it affects the central nervous system. Patients become scared. You got a tube in your throat, and if you try reaching for that tube to take out, guess what? You're going to be restrained. Now you're restrained. You got a tube in your throat. You don't know what's going on. No one's talking to you. So therefore, you're going to get scared. You're going to have an asynchronous event with the ventilator. Okay, if you're going to be scared, you're going to have a lot of fear. You might be agitated. Why? Because the respiratory therapist didn't set the trigger right. They didn't set the volume right. They didn't set the respiratory rate right. So for whatever reason, you're going to get agitated. All right. And the reasons why at times people do get a lot of anxiety and fear is because they lose control and autonomy. And ICU, you can't do anything. They won't let you do anything. Why? Because you're critical. All right. So, and then again, you can't really communicate with anybody because of the endotracheal tube. Now, some of the times I will talk to the patient and I see them looking at me. So what I do is I ask them, I go, if you can understand me, blink twice. And they'll blink twice. And I'll be, oh, okay, they understand me. And I said, okay. So then I just talk to them normal. But I want to make sure my questions are yes/no questions. They are close-ended questions, so I can understand the patient. Now, as a medical practitioner, you have to do your best to communicate with your patient. Sometimes the patients are out. They're knocked out, or they are just lying there staring at you or staring at the ceiling. I still talk to my patients regardless if they are not responsive to me at all, but they can hear. Hearing is the last thing that goes when you die, based on studies. So if that's the case, I'm still going to talk to my patients because it serves a couple of things. Number one, if I talk to them and I tell them what I'm going to do, they're going to relax. So regardless if they can understand me or not, they might hear me and be like, oh, okay, he's just going to give me a breathing treatment. I'm okay with that. That's not painful, right? And they might just be relaxed. They may just go back to sleep. Why? Because they know that you're not there to hurt them. You're there to help them. And they trust you, so they go to sleep. Number two, I talk to my patients because then it alerts staff to where I'm at. So if they need a respiratory therapist, they know where I'm at because they can hear my voice in a certain room 203 or 107. They hear me that I'm there, so therefore they'll say, oh yeah, I heard that he's over there, the RT's over there in room 107. So those are the reasons why I talk to my patients, because I want to try to communicate with them best I can, especially with the endotracheal tube. Worst case scenario, I'll just grab like a piece of paper and have them write something down, if they can. Sedatives, hypnotics, and neuromuscular blockers. We go into this a little bit more in detail probably later on. If not, I'll pull Pill Beams. Pill Beams has a good chapter on this. You have something called a Ramsay score. And if you have a level of 3 on the Ramsay score, your patient is responsive, they're not restless, so they are awake alert oriented. Okay. With these type of medications, they're used with mechanical ventilation to improve gas exchange, to avoid ICP spikes, to avoid hemodynamic instability, and to prevent bodily injury. The reason why is because we knock them out. Okay. So here is a slide of the Ramsay sedation scale. So based on the scale, you can see how well sedated they are. They are not sedated. They're a little bit. They're okay. First response, so they're still they're getting groggy, and then you can't assess them because they're paralyzed. So again, when you are setting the improper trigger, right, so you're increasing the work of breathing. All right. So a large dip or drop in the pressure at the beginning of inspiration, that tells you that the patient is spontaneously breathing. If it is a large dip, that means that they have to increase their work of breathing just to get the vent to trigger. Okay, so that's where this work of breathing. And I did talk to you a little bit about this in the lecture, where if you had auto trapping along with a baseline of +5 of PEEP, you would have to set your trigger or your sensitivity to a +7, so that it would trigger the breath, and that it would trigger the breath and help the patient breathe, and that's going to decrease your work of breathing. So again, this is how to fix it. Input trigger setting to -1 to -3. So if I am at 0, I have no PEEP, then I will set the trigger at this setting so they can breathe. Now you got to consider if they're at +5, right? And you want to set the trigger to +4 if you want them to breathe better. Okay? If a patient has auto PEEP set trigger to -1 to -3 centimeters below auto PEEP pressure. So again, if my auto PEEP was at 8, so here it is. Auto PEEP of 3 with a set PEEP of 5, then I'm PEEP 8, set trigger at -7, so that to decrease work of breathing. So VALI, ventilator associated lung injury. Now we can hurt the lungs internally based on how we set the ventilator. If we set too much pressure, we can cause a ventilator-associated lung injury due to barotrauma. So much pressure, to the point where you can give pneumothorax, pneumomediastinum, pneumopericardium, and subcutaneous emphysema. A pneumothorax has decreased chest movement, hyperresonance. So when you tap it on percussion, it's going to be more of a hyperresonant sound. Or it's like bouncing, I want to say maybe like a 4-square ball. I don't know if you guys remember playing 4-square when you were kids. Maybe not. Maybe I'm just dating myself. But these types of balls have this little high sounding ping to it. When you bounce it, it's going to sound just like that for a pneumothorax, and it's affected to one side. The telltale sign for a pneumothorax is any type of tracheal deviation. That's going to give you the location of the pneumothorax. For example, if it shifts to the left, then your pneumo's on the right, and vice versa. Okay, if you have some tension pneumothorax, you're gonna get some help, because that's a medical emergency. We're gonna have to poke a needle inside you to release the air, and then we're gonna put a chest tube again, and then so we have to use 100% oxygen to speed reabsorption. So this is the only time we're gonna hyperoxygenate our patients, because they have lost a lot of oxygen due to a tension pneumothorax. So along with pressure, we have volume related injuries based on alveolar distension, and we've seen that in the form of beaking. Increased alveolar capillary permeability, pulmonary edema, cell damage, and necrosis, diffuse alveolar damage, that can all be caused by our volume of ventilation. Overdistension again causes volume trauma and biotrauma. And then the definitions are like electrauma is when ventilating at low tidal volumes if alveoli are allowed to deflate and reinflate repeatedly for each breath. So we're constantly opening and closing those alveoli. They get irritated, so they're irritation. Okay, when you have irritation, you have redness, inflammation, so they start to swell up. Okay, so therefore that increases the AC permeability. Okay, so therefore it's going to have a decrease in gas exchange. Biotrauma is basically traumatic injury due to traumatic injury to lung tissue caused by excessive pressure. Releases inflammatory mediators, results in inflammation, impaired oxygen delivery, and bacteremia. All right, so we just don't want to overinflate, and we don't want to give the patient excessive pressure. Auto-PEEPing. Auto-PEEPing, again, same thing as air trapping, occurs if our expiratory time is too short for patient's condition. Again, to fix that, on volume control, we increase flow, which decreases I time and increases E times to prevent air trapping. All right, expiratory flow is interrupted by next breath. So yes, you start to what we call breath stack to the point where it's very uncomfortable. A lot of COPDers live that way. If you have the barrel chest, that is because you have auto PEEP and you've lived with it and you learned how to breathe with it. Okay. Auto PEEP, greatest risk with increased airway resistance and increased static compliance. All right. So obstructive disorder. So if I have a lot of secretions in my airways, again, I talked about laminar versus oh man, what's the other flow called? This is what happens when you try to do things at 1 o'clock in the morning. Turbulent, thank you. Turbulent flow. So with increased air resistance, you have a lot of secretions, which increases your turbulent flow. So then you have a high VQ ratio, therefore you have more dead space. So when you have more dead space, that's air being trapped in the airways. And then if you have an increase in static compliance, meaning to say your lungs can inflate well. So if my lungs are inflating very well, but my I time is prolonged and my E time is short, I'm going to be able to trap air in my lungs. Okay. Not included in measured and displayed PEEP value, so easy to overlook. Auto PEEPing, if you don't put that expiratory hold button, you can overlook it. Okay. Increase work of breathing by decreasing diaphragm's effectiveness and making it difficult for patient to trigger. So when you have increased work of breathing, that's gonna cause some asynchrony, which can also cause some auto PEEP. So you want to minimize the work of breathing by increasing your expiratory time, decreasing I time, and increasing PEEP set until patient can trigger. Watch auto PEEP does not increase with PEEP. All right, so now you have to consider what your baseline is, or what your PEEP is, and your auto PEEP, and your trigger. And you will know that you have to do that when you press your expiratory hold button. That is most likely the only way you can determine if someone is air trapping. I want you guys to remember that. Your expiratory hold button or your expiratory pause button will tell you if the patient is air trapping or not. So oxygen toxicity, it mimics ARDS in the sense that tissue damage with an increased AC permeability. So if you have the patient exposed for a long time, so this is associated with FiO2 greater than 50% for 24 to 48 hours. Now I'm going to tell you this in subacute, and I told some other students this in subacute at night shift. If you have someone with thick tenacious secretions, they're triggering the vent, and you want to have a quiet night for yourself and for the nursing staff, what RTs would do would be to crank up the oxygen. Now, if I had someone on a trach with a large volume nebulizer, cool aerosol, okay, they would crank up the FiO2 to 100%. So meaning to say, if they had a large volume nebulizer and on the dial of the large volume nebulizer, it would have the FiO2 and the flow. So it's almost like a Venturi. And it's working on the Venturi principle. What they do is they close off the air part and give 100% oxygen. What does that do? All right, oxygen is a dry gas. So therefore, it is going to dry the patient out. They're not going to cough as much. They're not going to trigger the high pressure alarm. And everyone's going to have a quiet night. So on their final rounds at 4 a.m., they're going to go back and they're going to switch the patient back to 100%. Now, on patients with who are on mechanical ventilation, what they do is they will give a treatment and leave the small volume nebulizer running. What is that doing? That's giving them more pressure. So you'll see if you give a breathing treatment to a patient on mechanical ventilation, your peak inspiratory pressure is going to rise significantly. You might see it at 1200. I'm sorry, that's your tidal volume. I'm sorry. Your tidal volume is going to rise. You might see it at 1200, 1500. Don't be scared. It's the small volume nebulizer. Remember, you are nebulizing medication with 5 to 6 liters from the wall unit. That's going to increase a lot of that tidal volume. Now, when they're done, they leave the small volume nebulizer on. That's how you dry a patient on mechanical ventilation. You run oxygen through the small volume nebulizer and you nebulize it throughout the night. Alright, so here's the problem. And this is almost close to oxygen toxicity. They run it for most likely, I'll probably say 10 hours out of their 12-hour shift. So here, it's at 50% for 24 hours. Right? So imagine I'm giving 100%. And I'm doing it every night. And so, yes, I'm drying them out, but I can slowly but surely start introducing oxygen toxicity into the patient's lungs. Right? So therefore, it might have some type of difficulty in gas exchange. So if I took a blood gas on them, I may have some abnormalities, and that might not just be due to the disease process, but it might just be due to night shift people leaving the SVNs on almost all night. All right, so you have oxygen-free radicals that increase your FiO2. Impair type 2 cell production of enzymes, superoxidize dismutase, which detoxifies free radicals. So we've heard of free radicals before. That comes in, it binds with stuff, and it just causes havoc internally. With these free radicals, it messes up cell production, and it increases AC permeability, and it decreases surfactant production. If I lose surfactant production, guess what? I have some atelectasis going on, and atelectasis can result to shunting. All right, VAP, ventilator-associated pneumonia. The way that we get this is that we have a pilot balloon on our endotracheal tube or our trach tubes, and we might have a patient with bacteria-laden secretions. Now, when we put in an endotracheal tube or a tracheostomy tube, and we inflate the pilot balloon. We do not inflate it to the point that it fully occludes the airway. Why? Because we have small capillaries running around the trachea. And if we hyperinflate the pilot balloon, we have a high probability that we will occlude these capillaries. Without these capillaries or small vessels, we may have an anoxic event to the point where necrosis starts kicking in. That's why if we do not have a manometer, we use minimal leak technique or minimal occlusion volume, MOV or MLT. All right, so we have to have a little bit of airway or a little bit of deflation so that we are not going to occlude the airway to the point where we cut off circulation through the pilot balloon. So since I have a little bit of an opening and I have secretions that are full of bacteria, they kind of bypass the balloon and they leak down into the lungs. That's how we get our ventilator-associated pneumonia. Again, intubation increases risk of nosocomial infections. Nosocomial infections meaning infections that were received in the hospital. So when we have a nosocomial infection, guess what? The insurance company is not going to pay for it. Since it happened in the hospital, it was the fault of the hospital. So therefore, the hospital has to pay the bill. And that's going to be pretty high. All right, so with VAP, it is going to be most likely picked up in the hospital. Now you have some microaspiration of upper GI or pharyngeal bacteria. So basically, it's not. It's more of the infected phlegm going into the lungs. So it says occurs around cuff or endotracheal tube lumen. Primarily more in the cuff because you get around the cuff and it falls in. So prevention of it. So basically gentle suctioning. We don't want to kind of cause any type of commotion when we suction to the point where it pushes the secretions down and into the lungs. Use of metered-dose inhaler rather than an SVN. Again, we want to avoid pressures pushing into the lungs. MDIs are more dry powdered, so it's going to be based on inhalation rather than any type of pushing of air or oxygen. Keep head elevated, yes, and then ventilatory circuit changed as seldom as possible. We don't want to break the circuit because remember, our respiratory system is a sterile system. All right, anytime you do some suctioning, nasotracheal primarily is going to be used with sterile gloves. A lot of RTs do not use sterile gloves because they just want to suction and leave. That's a no-no. Please don't be that type of therapist. So usually with the ventilator circuits, facilities have been changing them out once every month, or if they are visibly soiled. Where I came from, we changed them out every week. So we were constantly breaking the circuit, but we want to make sure that we limit the time that we break the circuit because, again, it's a sterile field or sterile system. Avoid or drain inspiratory tube condensation. You can have a lot of condensation in the tubes, primarily when you have cool aerosols. So you want to get those out. If you have a tracheostomy tube with a ballard, you might see a lot of fluid buildup in the ballard. If not, you might see it inside the HME. If they have a strong cough and copious amounts of secretions. So you want to clear that out of the way. Last but not least, daily sedation vacation to assess readiness to wean. So we don't want to continuously sedate the patient. We want to make sure that we can assess them in terms of when they're fully awake, so we can determine the readiness for them to wean. So you might have some complications. You might have a complication in terms of the ventilator. So if you have a ventilator malfunction, I had said either in this lecture or last lecture, chapter 45, if you have issues with the ventilator, don't try to mess with it while your coworker's bagging the patient. Just swap out the vent and figure it out later. But part of a ventilator malfunction is a patient circuit failure. Endotracheal tube problems could possibly be because of the cuff. A lot of times you lose a lot of volumes because of the cuff. Okay? Either you put too much air and the cuff ruptures, or less air and the tidal volume drops because there's more of a leak. Main stem intubation, I went the wrong way. I went further too far down, and now I intubated the right main stem bronchus, and so therefore you would have to pull back. That's why when you intubate, you not only auscultate for lung sounds, but you most likely per protocol you would have to get a chest X-ray for ET tube placement, and that's usually standard in a lot of the facilities. One hospital, I was shocked to find that they did not have that type of policy when it comes to endotracheal tubes, when it comes to also insertion of a gastrointestinal tube, okay, or a G tube. Circuit problems, you might have a leak in the circuit. Maybe there was a cover on the temperature port on the inhalation limb of the circuit, and now it's gone. So now you can't cover that pressure. You have to change out the circuit. You have a humidifier that overheats. That's going to be a really bad situation, because now you are burning the patient's lungs. Okay? Or humidifier is not filled. It's not filled up with water, so therefore you're not humidifying. Therefore, the secretions are becoming thick and tenacious and copious. Okay? Expiratory valve failure, you'll see that a lot more, or you'll catch those when you start doing ESTs or SSTs. Those are just testing that we do on the machine before we put it on the ventilator. Or let's just say we just discharge the patient on a vent, we clean the vent up, we'll run an extended test EST, and then we'll put a new circuit, and we'll put a bag over the ventilator for storage. So at least we know that when there's an emergency, we can grab the ventilator. We know it's been tested, it's passed, and so we just slap it on the patient. Let me see. Noted on ventilator by changes in frequency, tidal volume, and airway pressure. So if I have a leak, for example, my respiratory rate's going to increase. Why? Because I'm going to have a lack. It's a compensatory method. I'm lacking oxygen if I have a leak. Tidal volume is going to drop, so you're going to have a low tidal volume alarm kick in. Respiratory rate's going to go high. You might have a high respiratory rate alarm go in. And my pressure is going to decrease, because now since I am disconnected, or there's a leak, pressure within the tubing is going to go down, so you're going to have a low pressure alarm go in. And that's the beauty of the alarms. That's why we want the alarms, because in any type of failure, the alarms will kick in and ring. Now, it does its job. We have to do our job and answer the vent alarms. Okay? Ventilator failure, basically if it's an electrical, if it's something wrong with the ventilator again, go ahead and switch it out. And that is it, my RT230s. Thank you so much for listening, and hope you enjoy this YouTube presentation on chapter 46 and Egan's. It's a lot. And so, again, I just want to remind you guys about tutoring. Or if you have any questions, go ahead and put them on Google Classroom, and I will answer them to the best of my abilities. But most likely, if I had to answer questions, I want to be there physically with you, so that I can go ahead and and answer them directly. I am working on doing some type of conference calling. If you guys had issues, we can talk about it via Skype or some other way, and so that I can talk to you directly and answer your questions directly, just like that. All right, guys, thank you so much. Hope you guys have a wonderful time in lecture, in lab, and in clinicals in the days to come. And again, if you have questions, leave it in the Google Classroom. All right, thanks so much, guys.